society and GPs and other stakeholders. Marcy, thank you very much. He's just closing the door so our voice doesn't reach everywhere. Although we want our voice to reach everywhere in the Parliament, but not today. Other people get disturbed. So good evening, everybody. My name is Mushtaq Lasharie. I'm just coordinator of APPG on Third World Solidarity. My chairman, David Hudson, extend and send his apologies. He is in North speaking to another event which he never knew when we were organizing this meeting, even on 9th of April, when he met Zafar Khan in Kensington Town Hall on our 27th anniversary. He promised that he will come. I think Zabar, Arif and Asghar can endorse it and I can vote for it. He extended his apologies because he is there and he's speaking to another event. And I think we are very lucky to be replaced by a much senior member of parliament, much better looking member of parliament, and former Secretary of State for Environment and a friend of Pharmaceutical Society. So can I welcome you all on this second meeting of this sort, where we try to bring in the stakeholders from National Health Service, which is very important to everybody in this room and out there as well. And I think NHS is going through changes, and you will listen to many stakeholders today, President of Pharmaceutical Society, other senior pharmacists, doctors and others, and then at the end there will be chance you to speak, ask questions or contribute whatever you want to. I think we are very lucky. You know, the country, don't worry, it is not fire alarm, it is a vote or adjournment or whatever. Vote. So you are going to rush to vote?
Yes, very soon.
I know. So let me speak to you after Caroline has spoken, because I know it gives them 8 minutes to vote. So can I ask Caroline Spellman to come and say a few words and welcome you all in this parliament, and I can assure you she will come back straightway after about 10-15 minutes. Caroline.
And this will be the shortest speech that you will hear from a politician, because it's absolutely true, Mushtaq is right, that I do have to vote within 8 minutes. So you can watch the clock whilst I try and count down. I'm really just here this evening to welcome you to Parliament. Many of you may have been to Parliament before, but if you haven't, you're most welcome. And this is exactly what Parliament should be able to do, which is to invite in members of the public who all have an interest in a particular issue. And you're here tonight to address this well thought out question, really, about the role of pharmacy right at the heart of what the NHS provides, and how the different parts of the NHS work together around pharmacy in order to try and provide the best possible service to those who need it. I'm not a health minister. I've not had a health minister role in government. I was only in government for a very brief period of time. So regard me as almost like a customer of the services that we're going to be discussing tonight, because I have 3 children, and without upsetting anybody in the room, I would have to tell you that just today I tried hard to get an appointment for one of my children, still at school, and the best that can be done is in 10 days' time. You know, and as a parent, you know, that is deeply frustrating. So what will we do? We will go along to the local pharmacy together for some reassurance that actually the practice nurse, or perhaps it wasn't a practice nurse, just the receptionist at the surgery is right, that this can wait 10 days. But you know, there's really cutting straight to the quick of what we're here to discuss this evening. You know, how can we make sure that the NHS provides the best possible service? I'm a huge fan of the NHS. My sister has nursed in it for 35 years. And like the rest of you in this room, you know, I want to see the NHS go from strength to strength. And this is part of what we're here to discuss this evening. I'm going to dash off and vote, but I'm going to come back because I want to listen to you. I want to hear this discussion, and I want to hear what you have to say. I know that Jeremy Hunt is really determined that we provide more compassion through our National Health Service, that those who need help receive it at the hands of those who can provide that help in a compassionate way. Now, I'm sure that you do. All of you who are professionals and practitioners, I'm quite sure that's the way you go about it. But I think by debating and discussing together this issue of the role of pharmacy at the heart of the NHS and how we go on providing a really good service in the face of all those challenges of an ageing population in a resource-constrained world, I'm sure that I will find this debate and discussion very instructive. And I'm incredibly grateful to Zafar Khan for thinking once again how to bring you all here, coaxing and cajoling us into being here, quite right too. And I hope that we have a really good evening together. And I'll be right back. Thank you very much.
Thank you. I think Kiron is sitting somewhere in the audience. Could you come and take over the Caroline's seat, actually? Because Caroline and myself will be sitting in front to listen to all the speakers over there. So you take the seat, please. She is one of the speakers. I'm not going to start again, but I tell you, a couple of years back, when Zafar Khan organized a meeting in this room, and there were a line of Member of Parliaments here, I was asked to speak here briefly, and I said that the pharmacists are the front men of NHS. Everybody, when he goes to the hospital, or he goes to the doctor, or he goes wherever he goes, eventually he ends up with his prescription or something with the pharmacist. And the pharmacist always welcome them because they are the businesses and they are good businesses. So I was very pleased when Zafar opened up for 24 hours. I think it was the first one in London to open for 24 hours. I hope some of you will open soon and have a competition with him, but it is good to have at least one. So I always appreciate the pharmacist because sometimes, I don't know whether every pharmacist do or not, but there was a program a couple of weeks back in Newsnight and in Panorama that some of the pharmacists were caught selling some of the drug which is not prescribed or otherwise. And it was a negative sort of publicity to the pharmacist. I think we all should try to obey the rules as well. But can I welcome you all once again and hand over to Zafar Khan, who is going to run the meeting. Zafar Khan. Martin, the president, has to come on the stage as well. Martin, and I'll take up your chair. Go there. As I said, once they have finished their discussion, there will be question answer, and during that question answer, I will come back because they know that I'm quite good at picking up the people who are the right people to ask question or comment. So I'll come back.
We were just discussing. I want the president to go first and say welcome to you.
Thank you very much, Zafar. It's always a pleasure to be able to come along and join these meetings. They're always extremely well attended, and we always have excellent speakers that come along, and then when we actually open it up to the floor, it's always a very lively, energetic floor that we have. So I very much look forward to listening to the debates that we have. I'm delighted that Zafar has been able to pull all these speakers together, and I'm sure that without that sort of drive and enthusiasm, the Central London LPF wouldn't be one of the leading practice forums for the country. So thank you again, Zafar, and thank you on behalf of the profession.
Sorry about that little debate between myself and Martin. Yes, Martin has already said, I'm really pleased that we have got so many people here from the cross-section of healthcare profession. And I hope you're going to enjoy the evening. Mushtaq, Lasharie, Asis, Kiron, Dr. James, Cavanagh, Soni, Hemant, Patel, Zabar, Arif. Distinguished ladies and gentlemen, colleagues and friends, very good evening and a very warm welcome to you all in our 7th parliamentary conference meeting. Two of them, very kindly, Mushtaq Lasharie has assisted and organized for us, but the 5 other previous ones, you saw and heard Caroline Spellman. She's very kindly sponsored when I and Shilpa were sort of working together, and I've lost Shilpa since she has become the chair of the English Pharmacy Board. She's so busy now, I don't even get to see her. Allow me first to say a big thank you to Dave Anderson, MP, who is not here for reasons that he had to go to Scotland urgently, who has allowed this high-tech room for us to use. Also very grateful to Mushtaq Lasharie for his help and support. Like I said, we had previously 6 parliamentary meetings, and we talk about various health-related issues, and you very kindly come and support. Before I go on to talk about the meeting this evening, I have to say that today is an important historic day in the history of this country. Today was the funeral of the great leader, Mrs. Margaret Thatcher. She was born on 13th of October 1925 in Grantham and died on 8th of this month. She left one son, Mark, and a daughter, Karen, behind. She was the, as you know, First Lady Prime Minister of Great Britain, and she held the office from 1979 to 1990. Our thoughts today are very much with the family. To show our respect, can I ask you please to observe 1 minute of silence starting now. Thank you very much. We're just observing 1 minute of silence. I'm so pleased to see so many of you turn up this evening, despite many roadblocks. Many people phoned me and said that they wouldn't be able to come because they were fearing and afraid that they wouldn't be able to get here. But you all have shown courage to be here this evening, and I thank you very much. I can see Jean Gray from Nursing Stand. Ah, there you are, Jean. Thank you very much you were the editor-in-chief, editorial from Nursing Standard here. Michael Weeman and Salim Jetta, I've got the name. Jamshid Khan, Mutharik, Dr. Sood, Dr. Hart, Brian French, Jonathan, Michael Martin, Charles Willis, Jeff from PJ, And each one of you, thank you very much for coming, and you are very welcome. And of course, I want to thank the member of media and press who are here this evening. Cover Shilpa Goyal, who's sitting here. I mentioned her name before. And I want to say a big thank you to my steering committee. I'm just the front person sitting here, but they have been assisting me. Huge. Can you please stand up so everybody can see you? All my steering committee members, don't be shy. See, so many of them. And John is the man who does the money man. He controls the finance. I will always have to look towards him. And various healthcare professionals here this evening. And of course, you didn't get a chance to meet everyone. But let me see how many doctors are here. Please show. Excellent. Thank you. Any dentist here? So everybody can take a sigh of relief that they don't have. Nurses. Fair amount of nurses. Nutritionists. Martin, you are a nutritionist. Right, you've done, okay. Any other health care professional I haven't really covered? You stand up, say, pharmacist. Pharmacist. Yes. So you can see it's a nice balance, and this is what we try to get. We pharmacists are very keen to work with all the other healthcare professionals, and we are very keen to focus patients. After all, health is about the patient, and patient is our focus today, this evening. So you've given up your valuable time to come here to attend this evening. You are here because you want to hear what the patients have to say. You are here because you want to hear what patients' expectations and their priorities are. You are here because you want to hear how the healthcare professional respond to those needs and expectations of patients. And you are here because you want to hear parliamentarians, how they and influence their policies for better patient safety and better patient outcome. And as you are here, you should be taking a part in Q&A session later on in this and have your say. And that's why you're here. With these words, I must stop. You must be relieved that I'm going to stop now and let you listen to our learned speaker this evening. But before inviting our speaker, I would like to ask Alice Dartner, our LPF facilitator, to come and explain briefly how the evening lies.
Thank you very much, Zafar. I'll be very, very brief. Just wanted to introduce you to the speakers because we're very lucky tonight to have such well-respected professionals with us as speakers and panellists. I'd just like to quickly introduce you. First off, we will be starting tonight with Kurien, who will be representing the patient. Kiron is a patient with a long-term health condition herself, so obviously first of experience, and she will share with you her recommendations about improvements to the healthcare system. We also have Dr. James Cavanagh, who is back by popular demand and is returning to this event as a GP, but also this time as a GP Commissioner. We also welcome Soni, who is Vice Chair of the English Pharmacy Board, amongst many other roles and hats that you wear. And Ash was very pivotal and instrumental in the discussions with government during the healthcare reform bill. And he is here today to represent primary care in pharmacy. Representing secondary care today, we have Asis Khan, who's a specialist registrar in trauma and orthopaedic surgery. And we also welcome Zabar Arif, who is also in secondary care, who's from the Royal College of Nursing, and she is Deputy Chair of the Forensic Nursing. You've all got an agenda in front of you. We'll have an opportunity to hear from the speakers, and then we'll be welcoming the parliamentarians, and then there will be an opportunity for 20 minutes of questions and answers. So please don't be shy and do speak up. Back to Zafar. Thank you very much.
Thank you, Alice. Alice plays a very important role. She sort of facilitates us, LPF, who is headed by this lady here, Shilpa. She looks after all the LPF facilitators. I'd like to invite, remember what I said, that this evening is a patient focus. We want to hear patient. And my first speaker is Kiron. I hope I'm pronouncing right. She holds a BSc Honours in Food and Nutrition and has an MBA in Marketing. In 2012, she was certified as a tea trainer by Stanford University of the Chronic Disease for Self-Management Program, a program licensed by the Department of Health. She is one of 8 people in the UK to hold this qualification. Kiron combines her various qualifications and professional experience to provide expertise and consultancy services for a number of NHS and private organizations to develop, embed, quality assure, and build capacity for lay-led self-management program, while also being very engaged with PPI, patient and public involvement, in her local borough, which is Wandsworth. She also lives with a long-term health condition. Before I call her here, we have got a group of patients who are very kindly have come to support us here. Can I ask them to stand, please? Patient group who have come from Wandsworth. I thank you very much indeed for taking this. Kiron, please welcome him.
Good evening, ladies and gentlemen. It is an honor to be standing here today to represent the patient. I have, as Zafar has just said, got a group of patients here with me today. And I have worked with them, and we've had a focus group with my local NHS, that's Wandsworth CCG. They have had experiences both episodic and ongoing with the healthcare system. And together, we talked about what the experiences that each of them had. So what I've done for you today is I've put this together to tell you a story about M, so that I can illustrate the experiences that they've had. M is looking back to when this all started, when she started feeling unwell. She took some over-the-counter treatments and got better. However, off late, things aren't getting better, so she decides she needs to go and see a professional. She calls and books an appointment at her surgery, and she's told that since it's not an emergency, she needs to call at 9 a.m. on Monday morning to see if she can book an appointment for that week. She does that, goes and sees the doctor. The doctor is extremely understanding, listens to her, tells her that she's going to have to do a couple of things. Have some blood tests, go and see a specialist, and gives her some medication that she can use in the meanwhile to alleviate the symptoms. She takes the blood test form. It says she can go to Centre X or Hospital Y to have this blood test. And she goes to the pharmacy to buy her prescription medicines. She gets them, goes to work, calls Centre X and Hospital Y and realizes that the working hours means she's going to have to take some time off from work to go and have this blood test. She does that, waits for the letter from the hospital because they couldn't do it on the day. The children's book system was down. Over the next few months, she sees various people, she has a lot of tests, and finally she's diagnosed with a long-term health condition. The consultant tells her it's probably something that she's going to have medication for the rest of her life. She's going to have blood tests, and she's going to have regular checkups. Em leaves the consultant's office. She's feeling a little overwhelmed, and she's a bit unsure about what the implications of her diagnosis are. She starts thinking, maybe I should have asked some more questions. Maybe I should have asked for something in writing. What does this diagnosis really mean for me? Do I really have to take all these medicines? Will I be able to continue to work? And then she starts asking herself, why me? Why did this happen to me? She leaves the hospital a little dazed and realizes that though the world around her stayed the same, her life's turned upside down. At the pharmacy where she goes to fill her prescription, the pharmacist kindly tells her that one of those medicines that she's being prescribed is actually cheaper over the counter, so she might like to buy it over the counter. She does that, she goes home, she reads all the patient information leaflets on that group of medicines and starts getting a little worried and a little concerned. But she decides to trust the system and the people who prescribed it and plows on. A few months later, she's sure she's getting better. She might be having a few side effects. She has her regular blood tests and her checkups. And because her prescription is for 28 days, every 25 days she makes the journey to the surgery, puts in her repeat prescription request, goes back 48 hours later, collects it, takes it to the pharmacy, gets it filled in, and then realizes one of those medicines is not available, so she's going to get an owing slip and she has to come back again. She finds that the distraction of work is really good. It helps to pay for all the travel and the medication she now has to have. However, she finds that she spends a lot of time waiting for appointments, rearranging her appointments, ordering and collecting her prescriptions. And as she sees different healthcare professionals, every time she goes to the surgery and every time she goes to the hospital, she has to start telling her story from the beginning each and every time. She feels there's no continuity of care, and she finds it really hard to talk about her worries and her concerns. Besides, there's never enough time at an appointment to do that. She feels like she's on a conveyor belt, and she wishes that they would read the letters that they receive before she goes into the appointment, because that would make her feel like she was a partner in this team, and that they really care about her. Em is really conscious that she is desperately attempting to stay a person, somebody who can carry on with their work and carry on with their life and live alongside with their long-term condition. She doesn't want to be a patient on a long-term conditions register. And to succeed at remaining a person, she realizes she's got to do some things. So what does she have to do? She needs information. She needs to start asking questions. What does this medicine do? Why do I need to have it? Can I get information from anywhere else? Are there other options for treatment that I have? When she does get information, it's very rarely in simple, non-medical language. So she takes some time to decipher it. And because she goes around asking all these questions, she's soon described as that difficult patient who likes to challenge everything that the doctors and the pharmacists say. One day while at the pharmacy, a stranger there picking up their prescription tells her, you know, you might actually be eligible for free prescriptions. Why don't you check? And if you're not, there is a card, I think, that you can buy. And you just have to make one payment a year, or maybe every quarter. So she decides to ask the pharmacist, and she gets all the guidance she needs from the pharmacist. The pharmacist also tells her that she has the option of a medicine review if she has any questions about the medicine she's on. As life carries on, she finds that one GP in the surgery is very supportive. So being a good self-manager, she decides she's going to fit her appointments around the availability of that GP. She's able to talk to that GP about how different her life is with a long-term health condition. Listening to her, her GP tells her, there is a program called the Expert Patients Program. You might find that quite useful. if you're interested, why don't you call the number on this leaflet? Em decides to attend this expert patients program. She finds it's a self-management program for people living with long-term health conditions, led by people living with long-term health conditions. It runs for 2.5 hours, once a week for 6 weeks. And although there are people there who have completely different conditions, there are completely different ages, different backgrounds, they all share common symptoms, they all face common challenges. She starts to feel less isolated. Attending this gives her the ability to look at life completely differently. She feels empowered and confident and starts to look at ways that she can share her skills, her knowledge and the experience she's had with the system. She gets involved with her local healthcare organization through the public and patient involvement team. She now feels she is in control of her condition and no longer feels that it controls her. And she's actually very quietly pleased because she realizes and she says to herself, I think I'm me again. She continues to have to encounter the system, sometimes pleasant, sometimes not so pleasant. She feels that the system treats her a bit like a victim, a bit like somebody that things need to be done to. And the system is planned to work for the healthcare teams and not in her interests. She just has to go along for the ride. So after a number of years of interacting with the system, she's learned ways to manage the system and work with it, although sometimes things do happen which send her back to the beginning. New prescriptions, complications, acute conditions, new healthcare professionals, acute conditions becoming worse, becoming another long-term condition. And she finds that she has to start from the beginning all over again, because nobody's reading her letters and her notes and things like that. She feels that while she's so desperately working to be this person, she doesn't have much of a choice but to suffer the system and become a number on a long-term conditions register. And she wonders how much better it would be if the system was simpler, smoother, and joined up. And what would that system look like? She talks to friends and families, and she talks to carers, talks to other people with long-term health conditions, people of all ages and all cultures, and she finds that each of them have had similar problems and they face similar challenges. Together, they come up with a wish list of 5 things that will help meet the needs of the patient by joined-up working. The first, to be treated as a person, not a patient, a person who's kept at the heart of the system, created around them in a meaningful manner, making them equal partners in their care. Second, a service hub. Services together in one place that a person can go to where they are comfortable, which is easy to get to, and they don't have to change 3 buses to get to it. Where they can access services in quick succession, have their bloods, have a blood pressure, have their weight taken, maybe an X-ray if possible. The third thing that they would like is effective communication with the individual by and across the system. Maybe a summary of their care can be read by every member of their healthcare team. What medications they're on, what long-term conditions they have, what small episodes. Patients were very clear that they didn't want the complete notes visible to everybody, but just a summary of care would make a big difference. And that when people received these letters, they actually read them. If patients are given information, that this information is actually been test-driven by people who are living with the conditions, so that it's something that the patient can understand in language that they can understand. The fourth recommendation is appropriate medication information and reviews. Increased dosages on new prescriptions are marked and highlighted so that when it gets to the pharmacist, they know it's a new prescription, they know it's an increased dosage. They can stop and talk to the individual, find out what else they are on, Tell them, remember when you started this medicine, you were aware of these things. Now the dose is going up, you need to be aware of this. And finally, the cost of medication. That information on the PPC or the prescription prepayment certificate is made available by every member of the healthcare team to the person who's living with a long-term condition. And more importantly, that in the future, England goes the way of the other 3 nations in the UK, Scotland, Northern Ireland, and Wales, and provides free prescriptions for people with long-term health conditions, so that they don't have to make a choice about which medicine they can afford not to have because they can't afford to pay for their prescription. The group, and I have a request. For the rest of this evening, and going forward, that every interaction and contact that you have with a patient or on behalf of a patient, whether to diagnose, check results, dispense medication, formulate new policies, that you ask yourself, how would M view this interaction or this new policy or plan? Would it be one that she has to jump through hoops, difficult, stressful, disempowering, just like she had to in the past? Or one that M would call the perfect example of this new joined-up working system that met her needs, empowering, supportive, focused on her, making her an equal partner, if not the managing partner of that team. Thank you for listening.
Thank you very much, Kiron. I was very carefully listening. I think it's probably one of the best way by story you made us understand how perhaps the patient feels. We all are in that shoes one time or the other. We have, short-term illnesses, some of us maybe long-term. And we appreciate, but of course, our fellow patients who are here and who experience this, I couldn't have put better. Thank you, Kiron. Thank you very much. In natural succession, the next speaker, of course, would be a GP who actually the patient goes to. My next speaker, interestingly, he was born and bred in Chelsea, just around the corner of the pharmacy which I manage, and I've been managing for over 30 years. So I have been dispensing his prescription as a child, brought in by his parents who were both GP, and that's why he thinks, and rightly, that's in his blood. Presently, James is working in a large teaching practice in Brook Green, Hammersmith as a partner. He teaches trainee GPs and now sits in the CCG, the new clinical commissioning group. He works as an honorary consultant in obesity care at Imperial and helps us and head up Central Hammersmith GP network. He has worked with both CLARC and CLCH. James, you have to explain what these are. On several prescription initiatives looking at prescription in nursing homes and primary care in general. James admits that he is pro-commissioning, but not in the way it has been rolled out. He is highly supportive, thank you, of pharmacists and of integrated working. I knew James' father because his practice was very close to my pharmacy, so we became friends over the years. And I don't know those who were present here in our last meeting. I told the story. that my son, who you will hear later, was trying very hard to get into medical school, getting admission. And Dr. Cavanagh Senior, he wanted to tell my son that you have to try hard. So he said, you have to push the door to open. That's James' father, late father. I would like to ask James to please come and have the words.
Hello again. I've not really had an introduction like that before. I didn't realise I did so many things. Before I start, I'd just like to once again say thank you for your discussion about your history of patient care. I found it very moving, and I recognised all sorts of things from the other side of the table. So thank you again. It's great. I'm not sure how long I've got, and I'm going to try and keep it brief because there's a lot, and I think I really want to hear more from the floor than from us, to be honest. I am a GP, and I'm not speaking as a representative general practitioner. I'm speaking as a GP who has been seeing patients all day and spent 4 hours in the middle of the day at an integrated care meeting trying to work out how to better integrate care. So I'm a bit tired, but I want to get a couple of things across. First of all, I think all the points you made about patient-centeredness, ease of integration of your care are valid not only because it would make your care better, and your prognosis better, your morbidity better, but because we as a body of healthcare professionals have got to recognise that we have focused too heavily on the profession and what the profession does. And I think anybody who's aware of the Francis report sees that right at the middle of that report it states, nobody listened to the patient. And we all sort of sat aghast and thought, well, how's that possible? How is it possible for a patient lay in bed without water, uncared for? And why didn't anybody listen to it? And why didn't anybody listen to them? Why did it take such a long campaign from relatives for us to sit up and realise that we focus too heavily on the professions, and we need now to realise that this service is paid for by the public, it's there to serve the public, and we are public servants. And so, as a commissioner now as well, having looked at that and really been ashamed of what I saw from that report, I'm now very focused on thinking all the things I'm trying to commission, all the ways I'm trying to integrate care, what would a patient think about this? Because I can't really think as a patient. I've been in this profession for 20 years. It'd be wrong for me to say, well, I've been a patient and so I understand. I don't. And so more and more I'm trying to listen, and hearing you speak tonight has helped me a lot. I'd like to have more and more of that. Just briefly, in answer to some of your points, I think the patient-centeredness, absolutely, is key to the policies now coming out of central government, and people who don't listen to that are going to fall by the wayside. So I think you're going to see attempts at that. How effective those attempts are, we'll have to wait and see. The idea of integrated hubs where you can get everything done, I think we are trying to start doing that. In my part of London, North West London, we're doing something called Shaping a Healthier Future, where hospitals are being closed and other hospitals are expanding in size. And it's very frustrating dealing with that when you do see the evidence behind it and you hear a lot of members of the public protesting against it, and you think, well, why hasn't it been communicated in a way that they understand this is not about cost savings, this is about getting these large hubs. You can't have large hubs at the end of every street. You've got to do what you can do with the budget that you have, and this is an attempt to improve healthcare delivery with large hubs. So we are trying to do that. I think the third point about effective communication, this is about integrating IT. And we are trying to do that too. And the problem with integrating IT is that you have a lot of competitive tendering for IT services. I'm not making excuses, I've just been involved in one. And we wound up with 3 choices. And because of the way the contracts are organised, GPs can choose not to And so at the moment it's very hard to integrate IT, but I think that will come. And with that you'll find that your notes can be shared with your commission, and it will be down to the professional bodies to make it obligatory for professionals to look at the notes. We currently have a system like that in West London. All my patients' notes are uploaded onto a cloud. I don't know what that means, but that's what I've been told. And in theory, doctors who see patients in the hospitals can look at those notes. I've yet to see the notes being opened on the other side, because I can monitor. So it's great, we spend the money, we put the system in place, we then got to legislate to make people do it. It's obligatory. And again, that's down to the profession to do that. I think the last point I'd like to make is that I would also put the emphasis on you. Not so much you, you're here. But I'm very keen on my patients all being experts in their conditions. It makes life easier for me. It makes their care better. And when I try and engage a lot of patients in finding out about their conditions, finding out about their medication, empowering themselves, there is a degree of apathy. Not you lot, you're all here. But the vast majority of patients find it, they've been in some way disempowered. I don't know why, but you ask them to engage about their condition, and very few of them will step forward and say, right, yes, I'd like to become an expert patient. I'd like you to be my navigator of care, but I'm going to be the captain of it. Terrible expression, but that's one we use. And so I would say that my challenge is to the patients. Come forward, come to the CCG meetings, which are open meetings. Become involved in the commissioning of care and make these salient points at the right place, at the right time, so your needs and your preferences are put into the policies. Because at the moment, I go to CCG meetings once a week, and there's one or two patients that turn up to all of them, but nobody else turns up. So I agree with your points, but my final point is, come and help us. Anyway, I'll stop now, and nice to see you all again.
Thank you, James. I'm really pleased. James making notes and answering to the point by point. Thank you, James. Very, very focused. And I hope all the meetings like you will have a better work. My next speaker is a pharmacist. Now, leading into a national progression, I told you, patient goes to the doctor and then take the prescription, goes to pharmacy. Now, I'm going to ask a learned pharmacist to come. Soni studied pharmacy at Portsmouth School of Pharmacy. He graduated in 1983. Ash, did you know I went to the same place, Portsmouth? So, yeah, I didn't know that.
That's well, exactly. We kept it going.
All the great people there.
Absolutely.
His career began with Underwood in Central London and now runs his own pharmacy in Streatham since 1986. Ash qualified as an independent prescriber. This is a new breed of pharmacist who can prescribe independently. It's a good progression for pharmacist qualification. He's also working as in a sessional basis for a local GP practice. He's chair of a pharmacy advisory board at Pfizer, works on a consultancy basis for a number of pharmaceutical companies, and a vice chair of English Pharmacy Board. And I've got a chair sitting here. He also had recently appointed a board member of South London Local Education and Training Board, LETP, now known as HEE. There's so many words. He's a fellow of Royal Pharmaceutical Society and a member of Expert Advisory Board. Please welcome Ash Soni.
Thank you. It's a privilege to be here again, and thank you for inviting me. And I think it's, again, I've had two patient stories today. It's really interesting. I came from an event at the Royal Pharmaceutical Society immediately prior to this, where we were launching a commission on models of care, and about how models of care could be delivered better through pharmacy. And I think this starts to join them around together. And there was a patient there who was diabetic, type 1. And he described a very similar story. And in fact, his story even got to the point where we were talking about him having his HbA1c test, which is the test for his blood sugar. And he said, I have to make an appointment. I go to the doctor, I go get a form, fill the form in, I then go to make the appointment in the clinic, go to the clinic, and then they do my blood, then 2 weeks later I contact my GP and I get my result. And I said, oh, well, we've just started as part of NHS health checks locally. We provide an HbA1c test. He said, well, that's fantastic, because can I use that? How do I access that kind of thing? And I think that's a perfect example of where you can start to see some of the opportunity that pharmacy can offer and the work that we can do alongside general practice. I think there's some real learning from being patient-centred rather than building-centred, profession-centred. Because I think it works in a very different way. And I think we sometimes lose sight of that. I was slightly disappointed that you share your record through the cloud with the hospital. But you've got to share it with us.
Pharmacists were invited to the original trial.
But it's really interesting because as an independent prescriber, I have access to the medical record from another practice. It was really complicated. I had to go to Clinical Health to get the permission to do it and to prove what we were going to do and the fact that it was going to be safe and it was the right thing to do. And actually, I'm a health professional and I'm doing it on behalf of patients. So I will ask a patient, do you mind if I access your record? Because I think it's their record, their option as to whether I do it or not. So I think, and I think where it's happened, where we've had that opportunity, it is such a big benefit to the quality of care that we can provide. So I think there's some real working that we can do jointly as a profession. I don't know if anybody saw Roy Lilly. Roy Lilly wrote a blog. He writes a blog. He writes a blog for the NHS Managers website. He writes one every day. This morning's was quite a controversial one. It was forwarded to me by my CCG chair is here. I'm very lucky that Adrian's come. He's just literally flown back from a very important holiday. It's the first one he's had for God knows how long. Because he's been working so hard at making sure that the CCG got to where it got to. But he sent me this blog, and one of the things that struck me was that within the blog, Roy was quite negative about pharmacy and about healthy living pharmacy and some of the things we do. But what struck me is that Roy obviously has to do things which are controversial, because that's part of why people will read it. I think there's some issues we need to address about recognising the negativity that was in there and how we manage that and deal with that. But at the same time, I thought, Roy Lilly recognised healthy living pharmacy. That recognised the fact that there's a value in what we do and what we're delivering, and therefore he wants to write something about it. So we should see that in reverse as possibly as positive, and recognising that as valuing what we are trying to do and what we're trying to offer, supporting what we're trying to do. The other thing I wanted very quickly to do is I was, again this morning, I was at the Royal Pharmaceutical Society at the English Pharmacy Board, and we were very fortunate to have Steve Field came along to talk to us. And he used something which I think is quite powerful. He talks about the NHS Constitution, which is the expert advisory panel that I sit on. And he asked people, and I've done this a couple of times with him, he asked people to close their eyes and to think of the last patient they saw or the last care they got. And think about this statement. The NHS belongs to the people. It is there to improve our health and well-being, so we want us to keep mentally and physically well, to get better when we are ill, and when we cannot fully recover, to stay as well as we can to the end of our lives. It works at the limits of science, bringing the highest levels of human knowledge and skill to save lives and improve health. It touches our lives at times of basic human need, where care and compassion or what matter most. I think that's a really powerful statement, and it recognises how central patients are to everything we do. It picks up the stuff around pharmacists and the fact that there was a loss of recognition of care and compassion. It recognises the fact that everybody's trying to do their best for the patient, but sometimes we don't do it as well as we could. But we should always aspire to. And by listening and learning from patients, we can achieve much more. For me, the opportunity is about working together in a way which enables patients to feel confident and comfortable in their own care. And if that means that we have to negotiate a bit about what you do, what I do, how we make it work better between us, that's something we must do. And I think there are issues for us in terms of our contracts and how that operates. But ultimately, our role must be to deliver the best quality care we can for the patients we see. And that means that where possible, for me, and around things like long-term conditions, we have a situation today where every 6 months or once a year they have to come back to you as a GP. And you go, everything's fine, thank you, here's your next prescription. See you in a year's time or 6 months. You either put them on repeat dispensing or they have to come back and get their prescription. But actually, why can't we manage that care in a different way? Why can't we manage that care where the patient and the pharmacist, because that's where they're going, have an interaction and relationship around the medicines and the quality of outcomes and what happens to them. And when it sits outside a protocol, when it becomes a problem, they come back to see you. Because actually that's when they need to see you, not when things are okay. Because that gives them control. And if they're concerned, if they want to, obviously, absolutely, they come see you as GP. But it becomes, instead of being a way of ticking a box, it's about where and how is that valued as an interaction in the same way. And we have to recognise the changing environment in which we operate and the opportunities that we have for all of us. And I don't just think of pharmacy, I think of the rest of primary care, I think of the staff that work for us, I think of the patients that we serve, and the patient groups that there are, and how they all should work to deliver the best quality care around the patient. My last bit is that I'm a healthy living pharmacy. I have three health champions who are really good at delivering those messages around high quality lifestyle interventions. And I met someone today who was saying, oh, you'd written this piece about the public's health. And he was saying, what's missing from this? And I said, if you look at what you've got here, it's all about primary prevention. So preventing people at the beginning from becoming ill. That's fine. That's really good because we need to try and do that. We need to be much better at that. But what you're missing is that bit of holistic care for someone who has been diagnosed with something and recognising that they're not just ill and that's their problem. They are a human. They're a human being, and you recognise the other elements of quality around their care, the holistic approach, and recognising and supporting someone who is diabetic and talking to them about alcohol, weight, blood pressure, some of the other factors that influence and have an impact on their health that we should bear in mind, and that it's important for them to feel and have the opportunity to access that knowledge. So for me, we must be really careful that we don't try and separate out the condition from the person. And we mustn't separate out the person from being a human being. And I think we have all a responsibility working together with patients to make sure we make that work as well as we can. Thank you.
Thank you, Ash. Thank you very much indeed. So this was the primary care. We'll be listening to the patient, GP, and the pharmacy. Now there is another sphere which is a secondary care, hospital. And we were talking about integration and togetherness, and to show the togetherness, I'm wearing College of Surgeons, Royal College of Surgeons tie. So, my next speaker happens to be my son. He qualified in 2006 from St. George's University of London with BSc honours in his primary medical qualification. In 2010, he gained membership of the Royal College of Surgeons of England. In 2011, he commenced his specialized surgical training in trauma and orthopedic surgery, appointed by Severn Deanery based in Bristol. So he's still in Bristol. His interest lies in acute trauma care and hopes to specialize in trauma surgery upon completion of his training. He has worked in a hospital setting since qualifying in Surrey, Kent, Cambridge, and now in the southwest of England. Please welcome Asis.
Hope you can see that. Good evening. Thank you very much, ladies and gentlemen, distinguished speakers, who are all a lot more experienced than I am. I'll try and do the best I can and keep it brief. My name's Asis. I'm a trainee in trauma and orthopedic surgery, as my father's told you. I came this evening because I come from a slightly different environment to most of you. I come from a hospital setting which has a lot of similarities to primary care, obviously, but also has differences. And what I wanted to talk about was the communication between primary care, secondary care, when a patient needs to be referred into hospital for hospital treatment. So that's what I'll do. So what I'm going to quickly go through, I'm just going to mention briefly at the beginning something that I'm quite proud of, because I do like acute care, the sort of the acute side, of emergency side of healthcare in my job. So I'm just going to briefly mention what the major trauma network is, which hopefully none of you will ever have to come into contact with, but is there if you ever do need it. And then I'll talk briefly about quite key to. So where I work at the moment in North Bristol, it's an acute trust. Frenchay Hospital is one of the designated major trauma centres for the Southwest region. And that's a network, just like there's a network in London where King's and St George's and a few of the other hospitals at Northern River are all part of the same network. And what it basically means is, if someone is unfortunate enough to be involved with a significant injury, and that could be a road traffic accident, industrial type accident, where there's significant injury, multiple injuries, that patient, we now know, is better off going straight to a major trauma centre, even if there is another hospital closer. They're stabilised by the pre-hospital assessment, the team, the paramedics, sometimes doctors. They're taken straight to the major trauma centre, and it's been proven that the chance of survival and doing better is 20% better than having gone to their local hospital. And one of the main things is it's consultant-led care 24/7. So classically, consultants, you'd expect them to stick around in the hospital until about 5 or 6 o'clock, and then they would disappear and leave the rest of us to get on with it. But actually now, especially for major trauma centres, you will be getting consultant-led care 24 hours a day, no matter what time of the year it is. So I'm quite proud of that. So what's good trauma care? So in red, that's really the sort of steps. So the initial contact, when you first go out, paramedics, they find someone who's had a major injury. That team, the pre-hospital team, assesses them and decides how bad it is. If it's bad enough, they obviously get transferred straight to a major trauma centre, stabilised on the way. So they get their acute trauma care, they get the specialist rehabilitation at the trauma centre, and once they're past a certain point in their treatment, they're repatriated to their local hospital, who can then continue the general rehabilitation needs that they may have before they're discharged back to their home or otherwise. So the important parts of that really are identifying the seriousness of the injury, transferring them straight to a major trauma centre if appropriate. All the patients are assessed and managed according to a set protocol. Everyone gets exactly the same. And it's that standardisation of the acute care that has actually brought about a lot of improvements in the outcomes in terms of morbidity and mortality of the patients. So we don't miss anything. Everything is checked step by step. One of the other important things is specialist radiology, having access to a radiologist 24 hours a day. More and more patients coming in. Just last week when I was on call, a guy in his early 30s had fallen off a roof. He had fractures through his spine. He'd quite badly smashed up his tibia and fibula on one side. He came in, he was stabilized, luckily brought in by helicopter with a doctor on the scene, a pre-hospital doctor. And because he was so well, we met him at the ambulance door, took him straight to the CT scanner. He was run through the CT scanner, then taken for plain x-rays, and then brought to the resuscitation room in the emergency department. So it was slightly backward, but we were able to do that, and then we assessed him, and he was treated according to his injuries perfectly well. And it's availability of that specialty which has also made a huge difference, rather than just having access to just plain x-rays, which can sometimes be quite limited. So I'll go on to the main bit. I'll just talk quickly about what I believe is the role of the GP as someone who works in a hospital and someone who's been a patient of a GP. What the need is for secondary care, referral, subsequent care, definitive treatment, follow-up, and discharge back to primary care. So I thought I'd describe the role of a GP in pictures. I find GPs are the front line or the face of the National Health Service. They're the people that you go to when you have a problem, they're the people that you can talk to. I've been a patient on a number of occasions, and I've always had a good experience when I've gone to speak to my GP. And you know, it's nice having a rapport with the GP, someone that you can get to know as you grow and progress with your career, and someone that sort of follows you and takes care of you. And I think it's an important role, and I think they have the greatest respect for them. The bottom left picture is actually a picture taken from the Royal College GP website in the section about their curriculum. And no matter how much they have to learn, which is obviously a lot, it's care of the patient that takes the focus. They obviously have to know a lot, they have to keep constantly updated, and they're constantly doing great things in the individual GP practices to make themselves more accessible for the patients. So, very important. Now obviously, the general practice primary care are able to deal with a vast majority of medical and healthcare issues, but obviously, and some of you may have experienced this, you will then come across a certain chronic or acute condition which does require specialist input from a hospital, hence the need for referring into secondary care. Now I come from an orthopaedic background, so I'm obviously a bit biased in what I'm going to say, so I'm going to use examples from orthopaedics if that's all right. So for example, if someone has a painful hip, they've got arthritis, they would be referred in to see an orthopaedic surgeon who has a specialization in hip surgery. Patient choice is something that I think is good, because we get a lot of patients in Bristol who are from London. We've had someone from Kent, in Surrey, and they've said that we've heard that some of the surgeons here are quite good and have a good track record. And I think it's important to have that facility as a patient, and if you are someone that wants to know exactly the best person to go to, someone who has a good track record, being able to make that choice is obviously very important. So that is a facility regular. And obviously the initiative of the 18-week rule, where we try and see everyone and start their definitive treatment within 18 weeks, is obviously something we strive to do. So when you come to secondary care, you'll be seen initially by a specialist or a team from someone in the consultant team. You'll be diagnosed with whatever investigation is appropriate. We'll try and get it done in a timely manner. You'll have definitive treatment and follow-up. I put there communication with GP. Now obviously, as soon as we see a patient for the first time, we don't have the privilege that general practitioners have of knowing someone, knowing about their background. We meet them for the first time. Having access to medical records is one thing, but meeting someone for the first time is completely different. And so what I've been taught, having worked in hospitals, is someone will come in with a particular problem that they want you to help with, but a lot of my consultants have told me that once you've finished dealing with the problem that the patients come to see you for, once you're both happy that there's a plan in place, take a few minutes to talk to them about something completely different. And I try and do that in every consultation. Communication with the patient is important, but communication with the GP is equally important because you're taken out of a setting where you're more comfortable, where you're more familiar, where you know your GP, you know your pharmacist. You may not necessarily know the person that you're seeing in hospital. You may never have been to the hospital before. And we do our best to make you feel welcome, make you feel that you're being treated holistically, not just for the condition you've come to us for, but we also have to communicate every single thing that we do with the general practitioners so that they're fully aware of what's happened when you go back to them, when you're discharged. So every time I see a person in the clinic or we operate on someone, a copy of that is always sent to the GP.
And the pharmacist.
And the patient. Actually, yeah, that's true. A lot of the hospitals where I work now, the consultants make it a fact to CC a copy of every single letter to the patient, and I think that's a new trend that's also quite nice. Obviously, you have full access to your medical records in the hospital. There's obviously there's a process where you apply for it, but you can access everything. It's a lot more convenient if you just get the letters so that you don't have to remember each and everything from the consultation, which is a long process. So the only thing that I've come across a few times, and correct me if I'm wrong, that I thought was a slight issue was if we get referred someone for a certain subspecialty problem, so for example someone with a painful knee, and we're in the process of investigating them and it turns out that actually it's not their knee, it's coming from somewhere else, a problem in the hip can refer pain to the knee, a problem in your lower back can refer pain to the knee. We may not necessarily be able to refer you within the hospital to another appropriate specialist. I think what we have to do is refer you back to a GP, and we have to then, the appropriate specialist has to receive a referral letter, which obviously adds a lot of time to the whole process. Is that right?
Well, just to open up to the floor a bit, I don't have much time left, but do people think that's the right thing to do?
Yes.
Yes. How many people think that the specialist should not be able to refer to another specialist within the hospital, but they should write back to the GP and say, I found this problem, I think it needs to be seen by a consultant. Why? Would you consider that with the patient? How many people think that's the right thing to do?
I don't think you're, excuse me, I don't think you're listening to patients.
I agree. In my view, it's a real problem we have now that there's this moratorium on referring around to different consultants, and it's about saving money. And it's not about patient-centeredness, it's not about sorting the patient out as quickly as possible, it's about keeping costs down by pushing the work back out into the community. So I personally am against it, but I would agree that what does the patient actually want? The patient would like the problem sorted out as quickly as possible. And so if there's a consultant down the corridor or upstairs that would be better able to sort out the problem, why shouldn't you be seeing them the next day? Rather than it goes back to the GP makes a referral back to the end of the waiting list. It's lunacy.
Maybe we can open that up to the Q&A session later. Just want to talk about the discharge back to primary care, because this is a really important process. In orthopedics, the discharge planning starts as soon as the patient arrives in hospital and we know what we're going to do for them. We already have in our mind their background, whether they've come from a house, whether they've come from a residential home, from a nursing home, whether they have carers to look after them, whether they look after themselves, whether they live alone, whether they walk with a stick, whether they have stairs, whether they have a toilet downstairs or only upstairs. There's 100 different things that we have to address as soon as we see the patient, not just that they've come in with a broken hip. So we start planning immediately, and it's obviously a multidisciplinary team, including pharmacists, therapists, social services, and the nursing staff, as well as the patient and their family next of kin. And we all collectively have to decide what the best time and the best place is to send the patient with what package of care. So that process starts immediately. The discharge summary I just wanted to talk about, because there have been incidences. So this is a summary, as it suggests, of what's happened to you in hospital. A copy is given to the patient, and that's for their own records. A copy is kept in the notes, so that when you come back for the next time, it's available, and a copy is sent to the GP. Now, classically, they've been handwritten, and I'm guilty of this when I was a bit more junior, and I was doing more of these. You literally write down the absolute minimum. There's not really much information that goes on there, and it doesn't seem to be a very useful document. But now, with the advent of the EDS, the electronic discharge summary, a lot more information goes onto it. It is actually quicker to do, and as far as I know, every hospital that I've worked at does now use that service. And actually, in a lot of areas, I think it is possible to still send the electronic copy to the GP so that there's nothing lost. Because there's been lots of instances where GPs don't receive whatever we sent them in the post, a discharge summary or an operation note. And the transfer of care doesn't quite happen, especially if there is something needed from the GP or the primary care setting in terms of the patient's follow-ups, for example, wound care or other things. So, I mean, I've said a lot of this anyway, so it's an important document. It's very important from our point of view, from the GP's point of view, from the patient's point of view. We do try and make it as complete as possible. From a pharmacy point of view, the pharmacists do check that everything we do when patients come into hospital, we often get things wrong in terms of prescribing, especially when so many people have. We do now try and specify what's new and what's old, whether we've made any changes to their medication and why, whether there were any other specialists involved that we had to ask advice from, such as if the patient's blood pressure changed or their diabetes control changed. And it all should go into the discharge so we can communicate it back to the GP. Thank you.
Right. I'm very conscious of the time. We are slightly over time, running over time. So we are building a picture. We had seen the primary settings, and we've gone to a secondary care setting, and we've seen how the hospital is all about patients anyway. So we are still patient focused. In secondary care, I'd like to ask my next speaker, who is trained as a computer programmer from the American University of Beirut and worked in the Daily Mail in London for 2 years in the 70s. She always was fascinated by psychiatry and trained as a mental health nurse at the Royal Free Hospital, and subsequently as a forensic psychiatric nurse at Middlesex University. She worked as a team leader for North London Forensic Services for 15 years. Even though Zabar has now retired, she remains involved with the Royal College of Nursing. She was elected as the president of All Pakistan Nursing Association in UK in 2011, and also the deputy chair of the RCN's Forensic Nursing Forum. Please welcome Zabar, who is going to be very brief.
Excuse me, are you still intending to have the question and answer session?
Yes, of course. Yes.
So you're extending the time scale, are you?
Well, no, I think it will finish, but Mr. Hemant Jogi will speak only briefly. And I'll have a
Yeah, we will have that. That's the essential part of that. So, yeah.
Good evening, ladies and gentlemen. Thank you very much for inviting me today. And I'm actually conscious of the fact that I'm a very different kind of person to maybe, the kind of nurses you usually meet. And I certainly hope none of you ever has an opportunity to meet the kind of nurse that I am. But I mean, it was listened to Kiron, and what I thought was perhaps I could base the experience of nursing and secondary care on what she was talking about, of patient M, and basically base what nurses do on what the recommendations that she has asked us to consider today. So, just to start off with, to give you a very, very, very tiny brief background, I became a forensic nurse because I was fascinated by criminology. And rather than go and study that, because I was already a mental health nurse, I thought it was better to go and study how to care for people who had passed through the criminal justice system and had problems with mental health. So basically that was, those were the kind of patients we were looking after. They would come to us by referral from prisons or special hospitals, and nurses would go and do face-to-face assessments and then decide whether they were appropriate for our service or not. Now, I found it really interesting when Kiron mentioned difficult patients, because it is extremely interesting that there is a mindset in mental health that, again, the patient is done to. The nurse does the face-to-face assessment, there's no doubt about that. We talk to the patients about their expectations, about their needs. We discover what it was that led them to their behavior, what led to the problems they had, and actually then formulate a care plan or a treatment plan with the team, which consists of the consultant psychiatrist and the social worker and the occupational health professional. But there are patients who then want to know about the treatment, about the medication that they are getting, about the side effects that they are experiencing. Some of them are articulate enough to question why they should have side effects, whether there are medications that would have less side effects. So that actually resonated with me, because I've had so many conversations with patients about that. But just to then go back to the recommendations. Now, the first one was treated as a person, equal partners in care. Now, I know that nurses try their best to do that. I mean, in mental health, that is a given, simply because the length of admission is so long. I mean, our patients used to stay for as long as 4 years. So you really do get to know your patient, and the patient really gets to know the nurse. And in a way, the fact that they questioned their care was seen to be quite normal. Of course, there were situations where we felt that they had an unreasonable expectation, but most of the time it was quite appropriate as to what they were expecting and what we could deliver. The service access I found was quite interesting, because, I mean, obviously in a care setting in a hospital, everything is available in one place. The pharmacy is there, the various wards, of course. We have access to occupational therapy. They have access to means of going out for sports and for entertainment, cafes. So what their daily needs are, I think, met quite easily. And when they couldn't be, like patients have physical health problems. We had a patient who needed a heart bypass. So obviously we had to access a general hospital. And but the most interesting thing and the most important thing, I think, is point number 3, which says effective communication between members of the healthcare team and the language that is used. I mean, I used to be the team leader, and I was quite used to having my voice heard. And Warburton, the consultant, if he didn't agree with me. Because obviously it used to be, what shall I say, it used to then become an issue. Because my favorite words were, and I never had a problem using it, I'm the nurse. I see this patient 24/7. You only see him an hour a week. Who will know more? And that used to usually mean that the consultant used to back down. I don't know whether it was because he was expected to, or he saw the reasonableness of my argument. But I think it's extremely important that members of the healthcare team do know the patient, do understand the patient, do realize what his needs are, and accept that they are there for the patient. I mean, we never had a problem with when I say we, when nurses never had a problem with doing that, because that's what we were there for. But so many times, maybe the occupational therapist was supposed to come and do a program of their activities and would not turn up when they were supposed to. And then later said we had to go to a meeting. And the patient said, who is more important? Am I or the meeting? You know. So, and as far as language was concerned, again, there is the thing about mental health problems that people are not always articulate about. And we felt that when you bring it down to a human level, it becomes ever so much easier to interact with the patient. The other thing, the number 4, the appropriate medication, information and reviews. In mental health, that is considered very, very important because a lot of the antipsychotic drugs have a range of side effects that can affect the patient physically. And they then have physical problems due to taking the medication that keeps them stable, gives them a stable mental state. So to review that and to give the patient information to make him understand exactly why he's taking the medication and give him choices. There were so many times when, again, I knew there were medications that could be offered, and there was always a reason why that may not have been the case. So again, I found that extremely useful. And I think these things are so important for healthcare givers to know, understand, and then buy into, to actually say it. These are the 5 things. I mean, as far as the prepaid prescriptions are concerned, of course, the patients always had their prescriptions given to them free for long-term conditions. So, excuse me. So that was very, very, very useful. I mean, I really did sort of find a lot of the things that you said resonated with me. And I'm sure it will resonate with a lot of nurses as well. So as far as your request about every interaction or contact, I mean, this is very interesting because I remember one of my patients, he was moving into the community and the group whom he was going to, they were interviewing staff. And he was on the panel that was interviewing the staff. So when he came back, I was the team leader for his team. So when he came back, I was quite fascinated and I asked him, so how did the interview go? And he said, you know, Zabar, I was so surprised. You know, my only interest in a member of staff is, if I am having a difficult time, if I am having a problem with my mental state, what are you going to do for me? That's all I need to know. And he said, they had so much trouble telling me. And he said that was the thing that I was focusing on. So I think actually that goes to show patient focus. I think it's what we should always consider again and again, is the care we give, patient focus, because they are the reason for our being. Thank you.
I'm coming in because I know that there are some rules in this building and we have to follow them. and the rules are that if you have booked a room for a certain period, you can't go beyond that. I know our next speaker is very important. He has many talents, and he's got a long introduction which I will skip, because if I read it, it will take another 2 minutes. He did became pharmacist 3 years before I came to in this country, and I came to this country 32 years. Can I invite Hemant Patel to speak to us briefly, and then we will have a question answer.
Thank you for the brief introduction. It really saved me some embarrassment. Thank you. I think due to time, Chairman, I'll take no more than 5 minutes because I think people are ready to ask some questions. My job is to involve parliamentarians in this discussion. So can I just make 2 brief points and then ask if Caroline Spellman has got any comments to make, and then I'll try and move on. The first point I want to make is this. Medicines are poisons that we take, and we need to take them with a great deal of care. You need expert advice, and expert advice starts with the doctor selecting the compound, the dose, the pharmacist giving advice. So please do not forget, medicines are poisons that we deliberately take. The reason for that, for mentioning that, is cancer a big killer in this country? Yeah. Stroke? Can you tell me what the 4th biggest cause of morbidity and mortality is? Anyone? It's drug-related problems. This country doesn't even measure the damage done by prescribed medicines. And I think that the reason why I'm raising this is because drug-related problems result in harm to patients, particularly those on long-term conditions. And we need to have a strategy for measuring harm. 1 in 6 patients going into a hospital is going into hospital because of a drug-related problem. And we need to have a strategy to take medicines safely, effectively, and that gives patients good experience. So that's one point I wanted to make. The second thing is about long-term conditions and how they are managed, because 80% of pharmacists' work comes from repeat dispensing, which is associated with long-term conditions. 70% of hospital visits are due to long-term conditions. And the point I want to make is, in a controlled long-term condition, the place where that condition is managed should not be the surgery. It should be a pharmacy. And this is not about places, this is not about professions. This is about access to a healthcare expert when a patient needs it. And I really think the whole issue of self-care has been underexplored, and what we really need parliamentarians to think about is how do we develop good self-care and using everybody's skills to keep people in the community rather than in institutions. So those were the 2 points I wanted to make. And just a tiny little bit is people were saying, oh, they want an integrated care, they want a one simple building. Please be careful what you wish for, because you could get deserts where there are no health facilities. Because if you aggregate all the health facilities into one place, you will have to have buses and trains taking you there, and it will be arranged differently. So what I would say is, if you want a system, make sure it's a well-balanced hub and spoke system, so that your minor ailments and your controlled long-term conditions are managed as near to your home as possible, and other more serious conditions are managed in a local community somewhere nearby. So those are the points. Mrs. Spellman, do you want to just say something? Yeah. Thank you.
Well, everybody, it's incredibly hot got in here, so I think we should try and open these doors because I was on the point of passing out. And a good thing we've got so many medical professionals in the room. I'm also under some constraints. It's not, they won't sling you out, by the way, because you're here on an exceptional day, quite apart from Baroness Thatcher's funeral. One of the consequences, the House is sitting later than it would on a Wednesday. So all of this that you see going on is actually your taxes. So this is what's being debated, is how much of your money we spend on everything tonight. So this could go on a bit, but the speakers are very precisely timed, and you get cut off if you speak for too long, and that would apply to me as well. So I'm going to speak relatively briefly now, just to show you that I've listened, because I do want you to know, as a parliamentarian, I'm the only one in the room, so I've got to speak on behalf of all of us. You know, we do listen, and don't think we don't, because remember, like doctors, we have surgeries. I have 4-hour surgery on a Saturday morning on a councillor's day just outside Birmingham. I really see the slice of life that comes through James' surgery. In fact, I often say to the local GPs, we probably got the same patients quite a lot of the time. So I really would like you to know that I listen. So just reacting very quickly to some of this. Kiron, I think, spoke very strongly for the patients who are present here tonight, so don't think you haven't been heard. But I think she's gathered up all of those frustrations that you undoubtedly feel and conveyed them very eloquently. And frustrations that actually, quite frankly, we can identify with, because for whatever reason, one of the consequences of the way in which healthcare is structured in this country is that we feel extraordinarily disempowered. I have lived abroad, and it is very different. You're in the driving seat much more, but let's not forget that healthcare is financed very differently in other parts of the world. So here we have healthcare free at the point of delivery, and it seems to have some curious impact on us that we're just terribly grateful for what we give, and we don't question what we're getting, and we're prepared to wait for hours and hours and hours to get it. And even when we think possibly they've got it wrong, we dare not say. Now, I'm rather generalising, but there's quite an interesting thing psychologically. These health professionals showed me, as a parent and as a consumer of healthcare, they know absolutely what's not working. That's not in doubt tonight, is it? They've absolutely got it. They understand what doesn't work very well. The fact that we should even have to discuss putting patients first is actually quite extraordinary. You know, that should actually just be instinctive. But they, as healthcare professionals, know that it doesn't always happen. Now, spare a thought for the GP in all of this. I do feel for you, James, because the GP is, always has been, I think always will be, the gatekeeper to what we need. But actually, for a very serious reason, that, you know, as general practitioners, they see absolutely everything in the round. The difficulty is that, you know, they have a huge amount of pressure. James says he's tired. I'm not surprised that he's tired. He's trying to run a new commissioning process alongside seeing all his regular patients and being here tonight. That's enough to make you tired, anyone to make them tired. But what I would say to you in the nicest possible spirit, James, is that one of the problems is GPs have become less accessible. We can't access them that easily. And because more and more people are working probably longer hours, more complicated working, more part-time jobs, husband and wife both working to pay the mortgage, the fact that GP's hours don't sit very well to a lot of people's working day is actually quite a problem. We only really have time at the weekend to go and attend to things that perhaps are quite urgent, but, you know, we just can't take time off work very easily. So we are going to the pharmacists more and more because there's one in every town. There's more than one in every town. There's more, you know, if you're lucky, there's nearly one on every principal street. And so it's a pretty good quick access point, sometimes just for clarification, but sometimes, you know, for the well-worried, as well as for actually people who think they're okay, but just got a nagging doubt they're actually quite unwell. So I think together, as consumers and providers of the health service, we need to think that through. Asif, I'm so pleased you mentioned discharge, because to hear a consultant in the making elevate the getting rid of people out of hospital to the level of importance is music to my ears as an MP. Who do I see in my surgery? the people who've fallen between the crack of leaving the hospital and coming back into the community, typically on a Friday night when they get booted out because at the weekend there's only bank staff provision, they don't want them in over the weekend, and then poor old social services have to crank into action on a Friday afternoon, not the best one for them either, and get this person home. And we still don't, we do it better, as you described, we're beginning to get systems, but well done, but alongside your specialism, as an orthopaedic surgeon in training, to use but the exits on discharge, that's, that shows me sign of the joining up, which I think is a really, really good sign. And speaking to the nurse here present, I immediately feel I'm speaking to my sister, and I'll do exactly what she says. The power of the nurse, not to be underestimated. How many times have I been in a hospital when, you felt the harried consultant hasn't quite got time for you, and you often as a patient spend more interface time with the nurse. So I think, making greater use of the health professional who perhaps has just that little bit more time
and more knowledge.
Well, I will be careful what I say. A nurse may say that, and possibly contradict a sister. But actually there is something there about this. So I hope I've shown that I've listened to you. I hope I've shown the patients present that not only am I one of your number, even today, trying to get an appointment, that I've heard. And actually, the straight answer is we all in the room know what the problems are. Money has come up, but look, I think it's a bit of a red herring, actually, because we spend as much in this country now as France or Germany. It's the same percentage of our GDP as people who have completely different healthcare systems to ours. I think it's down to actually how the money is used. I have sat in hospital and seen money wasted. I'm sorry, but I have. This question about should we be providing people with long-term conditions with free prescription, well, common sense fairness tells you that we should, but then we've got to decide together what are we going to reduce to be able to afford that. Don't forget Scotland gets 20% more expenditure per capita on healthcare than England does, so it's a bit easier for them to provide that. But we're taxpayers, all of us I suspect in the room. These are the really difficult choices that the politicians have to make. They have to be guided by the healthcare professionals. How could I, without expert knowledge, wisely make that choice? That's why the GP is the absolute pivot in all of this, that they're balancing resources with their clinical knowledge. And that is why I'm pleased that the commissioning has come back to the GPs. But just a final thought, you can't win as a politician because people don't always want to hear the uncomfortable truth. And one of the uncomfortable truths is, we'd all like the services of a university-grade hospital at our local cottage hospital if we could. But the science teaches us that actually this specialisation is crucial to our life chances when the chips are down. And in the end, whatever system of healthcare you have, with however many resources you have, it has to be designed on the lines of the best clinical outcome, whilst remembering that what we're really dealing with, what is absolutely at the heart of it all, is a human being and a patient. So thank you so much. I think it's been a fascinating evening. I hope you have a bit more time to have your Q&A, because I suspect there's a need. No one will throw you out whilst we debate at length how much our taxes should be. Thank you so much.
Thank you very much, Cavanagh, and thank you for all that. But I want to tell them that in between the next speakers and you, they are in between you and a glass of wine, which has been provided by Royal Pharmaceutical Society, or a glass of juice and a sandwich. So don't speak too long, otherwise you will be deprived of that. Otherwise you can stay here as long as we want, because today the Parliament is sitting up till 10:30. But thank you very much, Caroline, and big hand to her. Now I know, as I said, there is some sandwich and drinks at the back, but any question or comment from them, and then I know that I will ask Martin to conclude, and they might respond to your question. So be brief and say your name, and we don't have microphones, so you have to speak as loud as I'm speaking. So anybody? Oh, yeah, I know Nigel. He was sitting here for 2 hours to ask a question and comment. Yes, I know. Yeah, stand up and say.
Nigel Crawford. I'm a diabetes patient in Wandsworth and have been for quite a few years. I think that the whole question of communications, which Kiron gave a very good story on, is so important. And I'd just like to raise, first of all, to thank you for the hearing loop in this room. And I can tell you, not a lot of NHS meetings do you find a hearing loop, and when you're missing it, bless you. So there are a lot of questions about communications which aren't always addressed. First of all, I'd like to come back, in fact, all, to what James was saying. Most patients aren't really interested. And we do hear that a lot. But communications is a two-way system. And, you know, whose fault is it? And I suspect it's a bit of both. And Kiron gave very good of the story of M, what the problems were, and M was mighty lucky to get an expert patient program, which is only a tiny percentage of patients. So what happens to the rest of the patients? How do they learn enough, as M had the problem, even to ask the questions, if the GP had time? And so we go on. And then the whole question of motivational conversations, which we've addressed with diabetes in southwest London, and we've had a coach on how to do that. Very, very interesting. But we've got a long way to go, I'm afraid.
Definitely, yes, young lady at the back.
Right.
Say your name.
My name is Doreen Novak. I am a community pharmacist, and I come across many of the things that we have heard today. I'm also a patient, and I've got a family, and they're also patients. We also go to hospital from time to time. My key thing is communication, and communication is the key. Communication with everybody and communication with the patient. I think there was a saying before, no decision about me without me. So the patient needs to be involved from the very beginning, and he has to have a say as to whether what kind of treatment they want, and they need to get involved. In addition, in this age of technology, there is no reason why the patient cannot have access to their own health records. We have we have our bank information on the internet. Why can't we see our health records? I had extreme difficulty trying to get the immunization schedule for my son before he went to university. I had to go to several places to get it. Why can't we have all of that in one place?
Thank you. Thank you. Any other? Young man at the back. Don't surprise, we are all young. I'm the youngest. Carry on. Say your name.
Yeah. My name is Ahmed Mohammed. With me, I won't talk about patient. I won't talk about really what the topic was about, but it's a related aspect. I think it is, all health professionals want the best for the patient. But I think this comment is for politicians. This is increasingly healthcare is done by non-professional people and people who have got a conflict of interest. For example, they would be selling cigarettes and at the same time operating pharmacies or GP surgeries. I think this is a very important point. And this point has to be looked into by the professionals and the professions, that people should not do and care for people when they are harming them at the same time. Thank you.
Thank you very much, Ahmed Mohammed. Next one. Yes. I think you are represented very well by Nigel and Kiron. Kiron spoke very well for patient group, and you are most welcome to say something. Yeah.
My name is Anna Tanner. I'm part of the patients program. I really wanted to talk about wastage, but it would be very detailed and probably boring. But the number of bottles that one gets, if you have a repeat prescription, you get these wonderful bottles of this safety thing, and I try to give them back, but if they have repeat prescriptions, they have done it already. So that's just a worry. It's going into landfill or whatever, we're paying for that, it's in the environment. The wasted medicine itself is also an issue, because you get huge things of betadine, which you're told to use sparingly. What do you do with the rest of it? And that's going into the environment as well, water tests and so on. So, just, I don't know who it is who can sort this out.
Thank you. I'll tell you.
It's a general point.
The next one. Yes, please.
I'm Dr. Hassan and I'm a community pediatrician. Maybe coming
Very
from...
famous name. Dr. Hassan.
Yeah. Just a comment from Kiron. We know about the changes in NHS which have been going on, and they have been in the stage of implementation. Since we talk about patient-centered, how much the patients and people at large know about these changes, let alone the healthcare professionals are not very much aware of it.
Thank you. Next one. Obviously.
I wanted to make a comment to James, because I'm a ex-hospital pharmacist. I was delighted to hear your view, James, that internal referral to hospitals are not in the interest of patients. I wondered whether you were going to look at this locally as your role in the petitioning group to change the petitioning rules when you refer patients in, so you can solve that, and whether you see this as one of the benefits of the petition arrangements that put you in charge.
Thank you. Can you come back after everybody has spoken, because I'm going to ask everybody to respond. I hope you will remember it.
I will.
Yes, lady at the back. Yep.
I work as a hospital pharmacist. We talked about access to GPs and how inconvenient it can be because they're only open in certain hours during the day. I think the same goes with hospitals as well. If a patient gets admitted into the hospital on a Friday night, there's worse prognosis for a Friday night admission than for a Monday morning admission. So I think it all kind of needs to be, when we're thinking about changing the NHS and commissioning, etc., we need to be thinking about some of those basic things about access and availability at all hours rather than just during the day.
Thank you very much.
I was about to say that I'm a student.
Say your name.
I'm Yemu. I'm a student, and part of what I do part-time, I work as a care assistant, and like what many patients say that some of the times we don't know what we're doing, like when you're working as a care assistant. You're basically just copying the care plan, and then you just give it to her nurse. Maybe she doesn't have any idea what you have done, and no one takes time to explain that stuff to you. And it's just a lot of protocol which removes the heart from caring for patients.
Thank you very much. Any other? Yes.
I'm Steve here. I come from a finance background, and I'm really emphasising how important it is for everyone to have access to patient records and all that sort of stuff. I mean, I'm a pharmacy student, and we've been emphasised and re-emphasised about how important it is to make clinical checks, check that all the medications are fine, and previous medical history might have an important impact. Now, if we can't access the information in community pharmacies, we can't do that. As a previous financial professional, I was able to access a patient's full details, including their history of where they worked, how they worked, where they used to live, and everything within an hour. And as a 19-year-old, I was able to access that. So to think that pharmacists cannot access that information is a bit sort of, well, off.
Thank you. Any other? Thank you very much. James, you started. Dr. James Cavanagh. If you stand up, I think it will be better. There is a microphone in front of you. I think.
I'll sit down, thank you.
So there are people I know at the back who want to listen to you.
You can hear me, you don't want to see me. Lots said tonight, lots of very interesting points, and I wanted to just respond to a couple. Patient-centeredness, access to your notes, access to appropriate information as quickly as possible in an easy way to use. We're all for this. It's your service, you pay for it. You should get what you need. I would just beware of asking people to extend their practice into areas where they are not fully qualified, where they are not fully experienced. It is a shame that people feel they have to go down to the pharmacist to get advice about a medical condition. I'm very pleased to hear that pharmacists are willing to give their advice. I hope their insurance covers them when their advice is incorrect. My insurance covers me. Does their insurance cover you? Because if they give you the wrong advice, you become unwell, and you are no longer able to work, who are you going to sue? So
pharmacists do have indemnity advice.
okay, I'd love to know how far the indemnity goes, and whether you have to keep notes on the advice you give patients about specific medical theories, and whether you do it for every single medical theory, as I am obliged to do. So yes, ease of access, but beware of getting advice from people who are not qualified to give you that advice. I know that's contentious, and I'm not trying to castigate other people trying to help patients. I'm just saying there are reasons why things are carefully legislated for. On the answer to your, and people are on the answer to your thing about changing the rules so that interprofessional referrals within hospitals can carry on, one has to remember why they stopped before you say, let's start them again. They stopped because it was felt that consultants were referring between them so that the numbers of patients going to clinics stayed up, so that clinics could qualify the budget they got. And it was felt that that was being done simply to keep the departments open and to keep the turnover in hospitals high. And so it wasn't actually being done always in the patient's interest. It was sometimes being done in the interest of the hospitals to make sure that they stayed financially viable. So
I just wish most hospitals were clever enough to do that.
Well,
okay. Time.
So what we have to look at is not that, we have to look at the financial arrangements that govern the finances that go into hospitals that keep them viable as hospitals. When we sorted that out, we can look at how we can do it and how we can do it in a way that is effective for the patients.
Thank you. Any other from the top? Yes,
Just a couple of things. One, I don't think that the profession, the health professional, I would be failing in my code of ethics if I was making the inappropriate decisions about what I can diagnose and what I can treat. I think I act as a gatekeeper, and a large number of patients.
Can you hear at the back?
A large number of patients do come to pharmacy because they do have the opportunity for access. And I must be honest, my sense of most pharmacists, and I suspect the vast majority, you have the odd one as you will in any profession, is that they will ensure that they do the best for the patient. They will make sure they refer them when it's appropriate. So I think we need to manage that and understand what the roles are, and not try. Absolutely, we mustn't try and do things that we're not competent to do. In the same way as we wouldn't expect a GP to do something they weren't competent to do. We have to be really clear. This applies across all the health professionals. And if I can just pick up this bit about waste, it's really strange this, but we have two problems. The one is that actually it's about the size of product that's prescribed. And actually, Benefit cream comes in two sizes. So whether you're given a small size or a large size, actually should be is part of the discussion. And something that you have the opportunity to comment to your GP about. In terms of bottles, the problem is that because they have been used to put medicines into, they become contaminated. And as Hemant said, they're poison. So if you put a different medicine into somebody's bottle and they happen to be allergic to it, you could cause serious harm. So unfortunately, there's a problem about recycling. And it's a real issue. And to be honest, hopefully these days, more and more are being prescribed in original can packs. And my view is that ideally, we should be in a position where all medicines are supplied in original packs. Actually, because that would make life a lot easier for patients. No, not at all. Not at all. I don't believe that's the case.
Let's have this debate later on.
No, I just, it's a general comment. I just want to give kudos to the on-call pharmacist. I know from being, say when you're doing out of hours, if I'm working on a Friday night or a Saturday night and a patient is taken ill and the duty doctor comes in and prescribes medication, I can say hand on heart, every single on-call pharmacist I've ever called for help has been there for the patient. Make sure that the medication that was needed was provided, even if they had to travel miles to come into hospital to dispense that medication. And I feel this is the venue where, with all these pharmacists, I must say, well done you, whether you were ever there for me or not, you helped the patient, because it was the patient who was in distress, and a nurse watching a patient in distress, it's very difficult to cope with. So thank you very much.
Thank you very much to the speakers. Thank you very much for coming. I know, I think I have learned a lot, and this is my only third meeting which I attended and spoken in many, and I have listened very carefully. I hope this debate carries on. But one thing is very important for everybody in this room. When you go home, please contact your local MP. Write to them whatever your concerns are. Whatever you have learned today from here, go and talk to them. Go to their surgeries. You have just heard that Caroline has told us that every Saturday she holds a surgery. You have MPs in your areas, you have councillors in your areas, go and meet them. And when we hold the next meeting, Zafar Khan Saab, who is the really front man in this whole activation in this building, I think we should bring in, as we have achieved today, many groups coming on one stage. We should have more MPs from different parties. I know why, and I don't want to discuss it tonight, why many MPs didn't turn up, because they are in the chamber, and you can see they are still discussing. And they are discussing a very important part of history in our United Kingdom. And as I said, many northern MPs have gone back to their constituencies to discuss it on the different level. So I wouldn't like to say more, but let's give a big hand to all speakers before I invite the President of Royal Pharmaceutical Society, which has given us the food and the backing for this wonderful event, and I hope we will hold another event in the next 6 months. Can I invite Martin Astbury to close the meeting?
Thank you very much, Mushtaq. What we've heard so far is the struggle that patients have to get the care that they need. Our responsibility as public servants with a role to serve those patients and the public. The need for joined up IT systems and access to patient records. That people with long-term conditions are just that, they're people, and should be treated as such. The need to streamline processes in secondary care and between secondary care, primary care and social care. At every point, we must ask ourselves, is this course of action in the best interests of the person who is asking for the help? We've all heard how professionals want to work together and for the benefits, to benefit their patients. But really where I want to finish and sum up most with is where Kiron started from. I think that was one of the best starts that we've had to one of the meetings that we've been to, one of the best starts I've had to most meetings I go to, where we're really being reminded what this is all about. And the wish list that you had, I've got written down, and I'm sure it's something that we all buy into. And hopefully I've got the reasonable summary of it. It's to be treated as a person, to have service hubs so you're not going from pillar to post, the effective communication with that shared summary care record, effective information around your medicines, whether that's through medicines use reviews or this idea of every time you get a new medicine or there's a change, there should be, I think it was used by James saying about there should be something in there about it being obligatory that the patient has the opportunity to speak to the relevant healthcare professional. I believe it would be the pharmacist to speak to in relation to what that new medicine is. And with the GP having written the prescription for that medicine. And then the cost of medication. Obviously, the RPS would like us to move to the same model that happens in Scotland and in Wales, where patients don't have to pay for their medicines. But certainly, it should be, for certain, all patients should be informed of either being able to pay for the prepayments or otherwise. And I'd ask, well, I'm not going to, you've already done enough, so what I'm going to do is Ash mentioned that there's a model on the same day today that we've had a launch of the Models of Care through Pharmacy Commission. Now that's being led, even though it's the RPS who commissioned it, it's actually being led by non-pharmacists, predominantly non-pharmacists. I think there may be 3 pharmacists on a group of 10 or 12 other healthcare professionals and patient groups. And I'll ask them to contact you, and hopefully you